Dear friends, warm welcome to MegaGen's video series. I am Dr. Segin Chandran from India, one of the MINEC Knights. And I am proudly presenting a case of mini implants, which we recently done in our practice. That is replacement of 3-1 and 4-1 for a young boy of age 18. He was reported after an orthodontic treatment where they could open up the central incisor space only for one tooth instead of two. And my challenge was to replace the same using a single implant. And after examining him thoroughly, I could see that it is going to be a really challenging case, as my osteotomy is going to be in the symphysis region, that is the fusion of two mandibular segments. And the space available and the prosthetic option is only for one single tooth. I decided to go with a very thorough planning and execution without giving any chance for a mishap. Though we are replacing only one central incisor, I could really see that the midline is not that important in this case because the lower incisors are not that visible. Upper incisors and the midline is masking the same. So decided to plan and do a digital wax-up using up-to gate. And we could see that the most ideal position for an implant, we were restricted to a size of 3 mm because we need bone all around the implant after the placement. We could plan the crustal placement, that is the platform of the implant, where exactly has to be the platform, how much depth we have to go with the implant, and what is the angulation of bone, and we could plan it in a three-dimensional fashion. When we realized that the crustal bone is very thin and it cannot accommodate even a 3 mm diameter platform, then we decided to do a crustal osteotomy and to take that autogenous bone for future buccal side grafting or the labial side grafting. And I could see that the bone available is ideal for placing a 3 mm implant, and there is sound bone surrounding that implant all the time after the placement. Now, when we examined intraorally, we could see that there is an hourglass shaped defect horizontally, and the soft tissues are following the same bony architecture. And we decided to give a off-crustal incision so that we get the maximum tissue thickness in the labial side. And that is very important when you wanted to have a good emergence profile. And we decided to go for a full thickness flap, including the periosteum. And that's how we can remove the crustal bone and harvest it. And at the same time, we can keep the periosteum intact for the future closure with the bone graft. And after reduction of the crustal bone, the implant bed was prepared in such a way that we could place a lancet drill and create an initial osteotomy. It is really challenging when we do it as a freehand surgery because a small error of a millimeter can go for a total loss of bone in that section. And when you wanted to progress with minute drills in that region, you have to be extremely careful that you don't create a labial dehiscence. So the drill sequencing was from the initial osteotomy to 2 mm drill and then 2.4 and then expanding it with an expander to a limited amount so that a final osteotomy was created. When we created the final osteotomy, we realized the fact that the defect in the labial side is going to be really a crucial factor. And the bone thickness in the labial side is going to be challenging to maintain the crustal bone in long time. So after placing a 3 mm implant with a 13 length with the minimal torque of 50 newtons, usually the MegaGen implants offer a greater insertion torque, but keeping the thickness of the implant well and the connection, the thickness at the connection, and it is only a 3 mm implant, we have to maintain a low torque value while insertion. So, an implant motor calibrated to maximum to 40 or 50 newtons is more than enough to place this type of implants, and an equisized osteotomy is always better. Then, you should know the implant system, what you are placing in that region. The MegaGen Mini Implant is one of the best two-piece mini implant systems in the world. It gives you a conical connection of 11 degree and it gives you an 1.7 hex, which is strong enough to withstand the compressive strength of an occlusal load falling into an incisor region. Added with its knife-edge thread and X-speed surface, it is going to integrate really faster, and that is how we can have a secondary stability, and it is going to take the prosthesis and it is going to maintain the bone all around it for a very long time. How can we insert a healing cap when we have given an implant with 40 to 50 newtons and you wanted to maintain a low torque value of 5 to 8 newtons for the cover screw placement or a healing abutment placement? A hand using fingers, of course, we can get up to that. But how to be very precise is using med torque. Med torque gives you a range of 5 to 35 newtons of torque for its abutment and the prosthetic component placements. When you wanted to go as low as 5 newtons, it is always better to use the med torque, which gives you a calibrated value. And again, after placing the implant, as we decided before, we went ahead with a GBR, a guided bone regeneration using autogenous. Graft is covered completely by the periosteum, the natural barrier membrane, and that is going to take care of the graft. So we have no intention to open up again or to remove the graft or remove the membrane or any other procedures are needed. Once we give the healing cap, the second stage surgery is avoided. Now, we have to check the stability of this implant what we placed. A mini implant offering an adequate primary stability of 66 to 68 ISQ value, that is by checking with the RFA, that is Austral, we can see that it is having an adequate stability too. Then the autogenous bone graft and a good closure and with a healing cap, we have done our job. This is where I stop as an oral surgeon and where my prosthodontist take over the case. When he is up to take over the case, he got multiple options. Since it is a two-piece implant system, he is having an option of using an angulated abutment or a straight abutment or a zirconia abutment or any of these choices, that the entire range is available in this mini implant system. The question is whether to use a single piece implant with an aggressively threaded one or to use a two-stage knife edge thread design and a two-piece implant system. A good emergence profile can be achieved only by good temporization and creating a good emergence profile that is possible only in two-piece implant system. The thread design and the X-speed surface gives you a OSHI integration in no time, and this is a boon for very challenging cases like this. Thank you very much, and I'll be again back with many other videos regarding dental implants and solutions offered in our practice. And thank you, Dr. Park and Team MegaGen, for giving us an opportunity to give lectures of our choice worldwide in a scenario like this where the conferences and all our meetings are cancelled and most of our dentists are sticking on to screen time and enriching their knowledge. Thank you very much.